Excuse me, everyone. We now have all of our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of today's presentation, we will open the floor for questions. At that time, instructions will be given as to the procedure to follow if you would like to ask a question. I would now like to turn the conference over to Ms. Anna Wojcik. Ms. Wojcik, you may begin.
Great. Thank you, Chelsea, and welcome everyone to the June National Content Webinar for the On the Cusp Stop Clotting in ICU project. Today we'll be talking about engaging the nurse, physician, patient, and family, as well as the CUSP topic for the month on the Learning from Defects tool. A quick reminder, as always, to fill out the evaluation at the end of the webinar. We really value your feedback and use it to plan further content. Today's presenters will be Jenny Tuttle, who is a clinical nurse leader at the Tucson Medical Center in Tucson, Arizona. Also have Dr. Kristen Coe, an assistant professor at the Feinberg School of Medicine in Chicago, Illinois. We also have Sue Collier, a clinical content development lead here at the Health Research and Educational Trust. Finally, we have Emily Pisola, who's our clinical nurse leader at St. Joseph Mercy Hospital in Ann Arbor, Michigan. So before I turn it over to our speakers, just a quick reminder about the platform. All of the materials can be downloaded in the materials box in the bottom right-hand corner. That includes the slides and a case study we'll be discussing today. You can use the chat box on the left-hand side there to post any questions, but please remember that we'll have a dedicated audio Q&A time at the end of the webinar. Okay, and with that, I'll turn it over to Sue Collier.
Thank you, Anna. I'd like to frame our webinar today with just a few learning objectives, and we'll ground the content you're going to hear today by starting out with a case study that will give you a sense of how we can begin to think about the work that we're doing at the unit level and how it engages all of the team members. So at the completion of this session, we will ask that participants be able to define nurse, physician, and patient and family engagement, and as a part of that definition, be able to list the benefits and examples of how engaging key team members as partners can be a key strategy in reducing CUSP in the ICU. And last but not least, we'll hear from Emily, who will help us identify some of the key elements of the CUSP Learning from Defects tool and how this process as well can be used to improve performance. So let's ground our work today by presenting first a case study that will hopefully give you some context as we begin to have conversation concerning engaging key members of the team. In our case study, Mrs. C is a 66-year-old female who is in the OR for an exploratory laparotomy. An indwelling urinary catheter was inserted in the OR, and the patient was transferred to the ICU post-op. The nurse in the OR gave reports to the nurse in the ICU. The next day, the patient is stable, and the indwelling urinary catheter is still in place. Mrs. C's son has been with her since surgery, but he's not been included in any rounds with the nurses or the physicians because they occur outside of visiting hours. Daily rounds and morning huddles did not include assessment of the indwelling catheter. By the next day, Mrs. C is febrile at 38.9 Celsius, and she complains of diffuse abdominal pain. Her white blood cell count has increased, and she has a cloudy, foul-smelling urine and a urinalysis that shows a positive for protein, nitrates, leukocytes, as well as white blood cell count, and bacteria. Her urine culture is showing E. coli, and her abdominal pain seems localized to the surgical area. That same day, Ms. C is diagnosed with a CUSP by the attending physician, and the physician orders a course of antibiotics. But during the morning huddle, the infection preventionist reviewed the prevalence of urinary catheter use in the ICU, and several staff indicated that a higher prevalence of UTI in the ICU is not unusual. When Mrs. C's son was at the bedside during visiting hours, he stated he was angry and concerned that his brother had an infection. So as you think about how this case study grounds our conversation today, think about three elements that really impact engagement of each of the roles we're going to be reviewing today: the nurse, the physician as well as the patient and the family. First of all, what are the concerns and fears? What might be some of the unique issues that each of these roles has relative to urinary catheters or CAUTIs? Ask, what do they need to know? What are the skills and the knowledge that will help them not only adapt or adopt new practices, but to be confident that it's the right thing to do. And this can include communication skills as well as information and education. And then last but not least, what are the system support elements that are in place? And what can the system do to promote evidence-based practice and a culture of safety? This can include things like policies and protocols, as well as checklists and any initiatives designed to improve how the team worked as a consolidated group. So with that case study as the grounds for our conversation, and with these are the three elements in mind, I'm going to turn it over to Jenny, who's going to talk about nurse engagement in the ICU. Jenny?
Thank you, Sue. Yes, my name is Jenny Tuttle. I'm the clinical nurse leader at Tucson Medical Center in the ICU. We do everything but hearts, basically. So as you see, we're neurosurgical, medical, very busy, high acuity unit. Part of why I've been asked to speak here is because I was a leader for this particular project at my hospital in late 2012, 2013. So they've asked me to talk about nursing engagement. So just a few slides. We've got a lot to fill in today, so I'll try and keep it short and sweet. Some of these things you guys have certainly already addressed, but just to back up. The biggest thing I found with nursing engagement, and I actually identified my own deficits. I could have done a little bit better job when I did this, but as the education staff, as laying that groundwork and explain to them the purpose, expectations, the who's, the what's, and the where's, and the when's. As far as the case studies, I think if you can bring in case studies that are very pertinent, happened on your unit, that will have more meaning for them. We have, for example, our director of infection control. Her mother died from complications of a CAUTI, and that's something she was able to share with us that really, it hit home a little bit more when you can really make it something tangible for the nurses. And obviously you want to review your current unit data. What's driving the reason for doing a CAUTI project? And we, at the time, had the worst CAUTI rates in the hospital. So what do we expect of these nurses? Making very clear goals. We actually, with the CUSP project, our goal was a reduction by 25% in our CAUTI rates, when in reality, our TMC, our real goal was a 40% reduction. So we had a couple goals, but they're very clear. What types of protocols do you have? Do you already have them there? Do they need to be tweaked? We are fortunate, again, 2012-13, a lot of protocols weren't out there, but we actually already had one. But we were able to tweak it and guide it with a little bit more of the HICPAC guidelines versus we had some pretty general reasons to have a catheter, and we found every excuse we could under the sun as a nurse to have a reason to keep one. So we changed those, tweaked our protocols, and educated the nurses on those. And again, what are the expectations when discussing CAUTI? The expectations being in your huddles, you're talking about it. Your bedside report, nurse to nurse, you're talking about catheters, tubes, and drains. Where are you doing your project? We started ours on our 450s unit, which is the ICU versus the CCU because we had the worst rates. And then we expanded it to the whole department, including the CCU. So figuring out where exactly you're having this, and then we end up rolling it house-wide. So just nailing down where it is you're doing all the project work. Certainly with physician rounding, we would bring up the tubes and lines, and even then we still have to remind them to do that. But the other big thing is every shift is important. And I can tell you my nurse champions at night were great. They didn't say it's not just a day issue, this is a night issue. And they really have made an effort to get those Foleys out at night as well. It doesn't have to be just a day issue. So really the expectation is every shift is responsible. And then certainly why, at the end of the day, why are we doing this? We need to provide them the stats for improvement or where we need to show improvement. And of course we know about the harm that this can cause and the cost. At the end of the day, it is a lack of reimbursement, but most importantly, it's the harm we can cause our patients. So as we all know, there's plenty of education out there to help our nurses better understand why we're doing this. I mean, I have my fright fact there that the estimated 13,000 deaths annually are attributed to urinary tract infections. And at the end of the day, too, we found out, because our infection control department really facilitated a lot of this many years ago, but it never caught on. At the end of the day, what it boils down to is nursing owns this. We put the catheters in, we take the catheters out. We have to sometimes remind the physicians. So the nurses have to own this, and that's where we really made some bigger impact is when nursing took hold of it and tried to make changes. Next is providing the tools to succeed. I can tell you many times, I've been an ICU nurse for 26 years and a leadership more in the last 5 years. Oftentimes I would sit in a staff meeting and I'd get the, our CLABSI rates are this, our CAUTI rates are this, MRSA, you guys need to get those down. But we were never given, they were just told to do it, but never told how to do it. So look at what you have as far as tools for your nurses to get this done. And by giving them the tools, you're going to engage them to help those rates go down. Certainly review your current supplies. We found we had one condom cap size only. We've expanded that. We've expanded to better chucks, premium chucks at WIC, because we also worked with our pressure ulcer department, our walk nurses, to reduce those, make sure that that wasn't going to affect them. But listen and identify opportunities to make workflow easier. So listen to those nurses, because as we all know, you're taking these catheters out, which at the end of the day, if you can reduce utilization, you're going to reduce your CAUTI rates. We saw that time and time again. What can we do to make their life a little easier if we can? Some hospitals, I was reading an article last week out of Medscape, a New York hospital, they were able to bring an extra tech. Not all of us have that luxury, so what else can we do? So listen to your nurses. They have some great ideas too, and we've had some simple great ideas on our end here. Again, give staff an opportunity to be a part of decision making. Sometimes you can't always do that. You just need to make a decision as a leader, manager, infection control person, physician. But if you can, and sometimes just bringing those little decisions can help them feel more engaged in the process and that they're a part of it and not being told what to do. And as we know, it costs more. Sometimes it costs more in supplies, but every CAUTI not only costs money but can risk a life. So our administration was willing to pay the extra things for certain devices, external devices, the premium chucks, and all those things, because we know at the end of the day, it's the patients that are going to benefit from this. Reminders will always help. We had some posters up. We worked with one of our hen groups, and they gave us posters. We were able to put them up, reminded them of the HICPAC guidelines, why we're taking out catheters. There's certainly T-shirts. Again, it's New York Hospital. They had Friday Foley's. So on Fridays, they all wore T-shirts to remind people the Foleys need to come out. Slogans, what you can come up with. We were creative. Some not always, clean, but I won't say some of them. But, whatever it takes for you to remind nurses, get it out there and have them thinking about it. And certainly computer-based assessments. Like I said, we had a protocol in place in our EMR that the nurses had to fill out every shift, but it's very loose. We ended up narrowing that down to the HICPAC guidelines, and our infection control department audits those. So it allows us to see which nurses are really using it, and hopefully it's reminding them to take those catheters out. Next is certainly making staff accountable. We can tell them to do these things, but unfortunately, as much as we hate to do audits, you still have to look at who's doing it and do they need to have a little chit-chat. So auditing and surveying, asking the open questions. I did find when I was auditing my nurses or going around, hey, why we have this Foley today, and I'll get my reasons, and they can give me legitimate reasons. If they hemmed and hawed, I would start opening the questions. Well, let's see. If you don't have a reason, let's consider taking it out. And I had nurses say, well, but they have Lasix, and I'm like, not good enough unless it's acute. But at the end of the day, I had to kind of push them a little bit and say, okay, well, let's just take the catheter out because we do have the protocols in place. So you have the opportunity to track them. If we need to, we can put the Foley back, but we never gave them a chance to be continent. So let's take it out and let's see what they can do. And we found that more people can tolerate having their catheter out and do fine. And, of course, we all have bladder scanners anymore. That's a tool of the trade we all have to have. So it's open questions. Just don't settle settle with the answer of, well, they need it. No, tell me why they need it. Let's see, well, why don't we think about taking out what would be the worst thing that can happen? Nursing-based, again, back to if all fails, we take that out. We can fall back on our nursing-based urinary insertion removal protocol. So are they using it? Last is accountability is providing that current data. We had a big bulletin board, and what I ended up doing at the end of the day was we had done great. We started having a few more CAUTIs back up. So on the big board, I broke my 2 units. This is when we combined both of our ICUs to look at CAUTI rates. So I broke it down to ICU and CCU and said, okay, here's a CAUTI. I write the name and the date. This is a lockable room. It wasn't a HIPAA violation. But I was able to say, hey, let's talk about this person in the huddles. I said, they got a CAUTI. And putting a name with a date and the nurses having to talk about it, it made them more accountable. And it's like, oh gosh, I didn't realize they got one. We need to work on that. And certainly unit newsletters to get that information out to staff. And lastly, it's acknowledging the successes. Sometimes we can't afford to give them a gift card to Target every day just for taking a Foley out. But I was able to piggyback on another program we had here at TMC, which is a culture change. And for example, I was able to give out little plastic coins, which got them a soda or a cookie at the cafeteria. It's not much, but I was finding nurses were coming up to me saying, "Hey, I got my Foley out. Can I have my change?" And sure enough, I was more than happy to give those out. So it changed the culture there, and it had them thinking about getting the catheters out. And even now, even though I don't use that change anymore, because that's been, like I said, we did this 2013. I still have an occasional nurse come up to me and say, "Hey, you'd be proud of me. I got my catheter out." I high five them. It's just the little things. It doesn't take much. Again, this article, I like this article I read last week from North Shore University Hospital in New York. They had a really great idea, and again, something that makes it more visual for nurses. They had a sunflower, and what they did is they added a leaf for every day they were without a CAUTI. And I think that's a great visual reminder and ability to show the success of that unit. So those are the areas I think were primary in getting nurses engaged in my unit. Just one thing, when I looked at the case study, from a nursing side, the thing that jumped out at me was, number one, and it's kind of a side note, but the visiting hours. We've gone to 24/7 visiting hours years ago, which allows the family to be there when they want to be at change of shift, and we let them be a part of the bedside report. So there they can hear and understand what we're doing. So that's something I would probably consider based on this case study. Certainly daily rounding. That's where they can also hopefully be in making sure that the physicians are talking about those catheters, maybe be a part of that conversation. I didn't see protocols to remove this. It's interesting, this case study hit home for me. I had a patient who was post-op day 1, abdominal surgery, exact same case scenario. So we withdrew that catheter on post-op day 1. We took it out because it met the criteria. The patient was awake, alert, able to void on his own. And then I had a surgeon come back later in the afternoon who was not very happy that we took that catheter out. So, in fact, he may have put it back in. So I'm sure Dr. Koh will be addressing how to talk to physicians, but our intensivists are on board, but not all of our surgeons. So hopefully we'll get some help in figuring out how to address the physician issue. Judging from the criteria of this case study, looks like an insertion issue, and again, that falls back on nursing. This is something that was this CAUTI caused due to insertion since it was 48 hours later, or within 48 hours. So those are some of the things I identified in the case study, and I'm sure you guys can see a bit more. But thank you for your time, and I'll let Dr. Koh take over next.
Okay, thank you, Jenny. Well, let me just preface this portion by saying that I do have a lot of slides, which I will go through quickly in the interest of time, but I wanted to provide the full set so that you can peruse them at your leisure later. So next slide. So our agenda for this segment will be to define physician engagement, understand the scope of it with respect to the county project, identify the challenges, look at the solutions, both general and specific, and then finally synthesize all of the information and distill it into a summary for easy reference. Next slide. So there's no one universally accepted definition of engagement, but one that we can use as a starting point is that it is an intentional and deliberate process to bring physicians and other stakeholders together to address problems continuously and to improve care and the patient experience. Next slide. Another way to look at it is that when physicians are engaged, they invest their time, demonstrate curiosity, show enthusiasm, contribute in various ways, and then begin to influence others to their way of thinking and behaving. Next slide. So why does it matter? Well, the evidence does suggest when physicians are engaged, that is linked with better outcomes and greater success in quality projects. Next slide. So now let's look at the scope of physician engagement. There are three main types of physician stakeholders in the context of this project. The first is the medical executive, and this group consists of physicians who may be CMOs, DQOs, VPMAs, etc., as well as medical executive committee members such as the chair of medicine and surgery. Then we have the physician champions, who are, of course, the doctors with whom you'll work most closely within this project, and they can be a hospitalist, ID physician, urologist. And the third group are the individual clinicians, and we'll divide them into the non-surgeons and surgeons, and more to come on this particular taxonomy later in the presentation. Next slide. So why is it so challenging to attain engagement? Next slide. Oh, I'm sorry. That's the correct slide. So several reasons. First is that organizations likely have different goals and incentives from physicians. They may actually be in competition with one another. And second is the physician culture can also be a barrier. Doctors are trained to be autonomous and independent rather than team-oriented. And there's always concerns about medical legal implications behind every decision that's made about a patient. And third, the work life and workflow of physicians is another challenge. They have limited time, can attend at several hospitals, and may not have a particular loyalty to any one hospital. And a lot of physicians are not aware of quality and safety projects. They're really more focused on that individual patient, not so much on systems. And many don't have the QI skills or the language or the concept. Next slide. So now we'll look at solutions. We'll start with the general and then move to some more specific and practical solutions. So the three general approaches include first the 6 drivers as identified in a study of 10 of the best healthcare systems in the U.S., the IHI framework, which also has 6 elements, and then, of course, the CUSP model with the 4 E's. And as we talk about each one, we'll be moving from how to get collective engagement of physicians to more individual. Next slide. So this was a study conducted by some Harvard researchers on the 10 best U.S. healthcare systems. They identified 6 drivers for strong engagement. The first was to have engaged leadership. The second was to have a physician compact. And a compact is basically just the rules of engagement and the expectations for physicians and the institutions. The next driver was appropriate compensation. The fourth driver was performance-based financial incentives. And at academic institutions, promotion was also a driver. And then finally, there was the data and enablers. And by enablers, we mean the processes and tools that enable physicians to take action to improve care, such as the electronic reminders, clinical guidelines, and protocols. Next slide. So the IHI also looked at some of the best healthcare systems in the U.S., including Mayo. They also looked at the British National Healthcare System and came up with a framework for engaging physicians in quality and safety. They also had 6 elements in their approach. The first was to discover a common purpose. Secondly, to reframe values and beliefs. Third was to segment the engagement plan. Fourth was to use engaging improvement methods. 5 was to show courage. And 6 was to adopt an engaging style. Now let's look at each one a little bit more closely. Next slide. So for the first element, it's to discover a common purpose or shared vision. Both hospitals and physicians want to have good patient outcomes. They both want improved efficiency and decreased wasted time. They both have professional pride and want to have an excellent reputation. And for some physicians and hospitals who are perhaps more self-actualized, it may be about contributing to a cause greater than themselves. So hospital leaders should provide an exciting organization vision to really engage physicians at the highest levels and help them to feel that they're contributing their time and energy to something great and worthy. Next slide. So the second element is about reframing values and beliefs. And rather than seeing physicians as customers, they should be viewed as partners. And the only customer really should be the patient. And of course, this requires a change in beliefs and attitudes. Next slide. The third element is to use segmentation, which is to more or less divide and conquer. Look at your physicians to see who you should focus on to get the most optimal results. Apply the Pareto principle, which is also known as the 80-20 rule. And in this context, it is essentially about focusing on the right 20% of the physicians to get 80% of your results. Next slide. The fourth element is to use engaging improvement methods. Physicians are scientists and they respond to data. So show them that data for feedback purposes and do it in a rapid cycle to generate momentum. No physician wants to be a data outlier unless it's in a good way. And use the data sensibly to generate awareness and enlightenment, not to inflame or for punitive purposes. And show evidence-based guidelines as needed. Next slide. Next, show courage. Any improvement will require that people change, and that may not be taken well by those who are comfortable with the status quo. But have a belief in what you're doing, and there should be backup for you all the way to the hospital board. Next slide. So the last element is to adopt an engaging style, and this is about involving physicians from the beginning in the plans, designs, and decision-making process. And not only with those who are enthusiastic, but also invite the critic. You'll get to hear where the potential pitfalls may be that you may not have thought of and get a better outcome. And at least once they've expressed their concerns, while you may not get full embracement, there's probably less chance of getting undermined in the future. Next, build trust one project at a time, communicate often and regularly, and value their time by scheduling meetings when they're most available. Next, we'll segue into the CUSP model's 4 E's for engaging physicians, and I think that it will complement this last point from the IHI framework well about adopting an engaging style. Next slide. So the 4 E's engagement model will assist in identifying and engaging physicians or others to your team. It was created by the Johns Hopkins Quality and Safety Group, and it has 4 elements. The first is to engage, and this is about answering the question of how does this make the world or ICU a better place? And this work is really the adaptive work, where the unit teams help staff understand the results of the CAUTI, and they can do it by sharing stories or estimating the number of patients who are harmed. And by emphasizing this sort of involvement, it not only helps with the success, but also the sustainability of the effort. So the second E is to educate, and it's about what do we need to know. And it involves educating the staff and senior leaders so that they understand what their roles and responsibilities are with the CAUTI project. The third E is about execution. It's what do we need to do. This also involves adaptive work, and it's where the unit teams apply a plan of action based on the unit's resources and culture, and then analyze their roles within that plan. And then the final E is to evaluate. It's how do we know that we've actually done any good? And so this is about where the unit teams collect and submit data to analyze the success of their efforts. Next slide. So now we're going to discuss some more specific solutions for attaining engagement from the particular physician stakeholders. So again, our stakeholders, as mentioned, are the executives, the champions, and the individual MDs. Next slide. So within the medical executives and the MEC, consider doing a cultural assessment to get a temperature of ultimately how easy or difficult this new project could be. There is a tool by the IHI that has 7 questions that you can use to kind of gauge that temperature. And when you're ready for the next step, present data on CAUTI initially and regularly to the MEC, and to really get their attention, present on the business case for CAUTI prevention. There is a cost calculator on the website Catheter Out, and a CAUTI can increase length of stay by 2 days, and that can mean a lot in the eyes of an executive or an administration if you can reduce length of stay by 2 days. Also discuss the CMS policy for non-reimbursement of CAUTI. Next slide. In choosing your champion, pick one who's respected, courageous, sociable, has good communication skills, is intrinsically motivated, and really any clinician who's interested in quality and safety. But don't choose someone who is a full-time physician administrator. Your champion needs to have that street credibility, so to speak. Next slide. So the responsibilities of the champion will be to communicate with other physicians about the project, educate the medical staff on the indications, assist with process development, assist with implementation of the components, and then help to remove the physician barriers. And this is probably the true test of that physician champion, is when he or she encounters that resistant physician. Next slide. So once you've recruited your champion, some additional things to equip and support them in this role. First is provide them with some material. Consider like an electronic information packet so that they can get up to speed on the technical and adaptive components. Have them collect with their executive sponsors so they know they've got backup when it's needed. Connect them with other physicians who are the early adopters who can support them. Have a communication plan. And then consider some sort of reward or recognition as a gesture that you value their time and contribution. Next slide. So this is a sample script that can be used by your champion or nurse champion for that resistant physician. It's adapted from the IHI, and I think it challenges that resistant physician to try and change, but not in an overbearing or inflammatory type of way. Next slide. So some more tips and techniques to get engagement on an individual physician level, and these are arranged to some degree on difficulty of buy-in, so that the further down the list are the tactics for the most recalcitrant. First, and very importantly, make it as easy as possible to do the right thing. Have automatic stop orders on Foley's, involve physicians early in the design and planning, have your champion present at meetings, provide data and feedback to the outliers, as well as those who are doing well for positive reinforcement. Appeal to professional pride to the data. Engage your medical leadership support. Use scripts to explain the rationale and to engage, and then frame it as to why they should care or be involved. For the laggards, have one-on-one education. Listen carefully to the resistors, and then ask them directly if they're still resistant, what would it take for you to participate or be involved? And then consider rewards and recognition later for those who deserve it. Next slide. So we'll turn to that last group of physicians, the surgeons. And this is a slide from Dr. Sanjay Singh. So surgeons as a group in general, they're very tribal, and they'll listen to someone who they consider to be their peer, which is basically another surgeon. So the bottom line in overcoming resistance from this group is to have another surgeon on your team. Next slide. So we've looked at solutions, but we should also touch on briefly what not to do. Don't use inflammatory language. Be careful in the messages and the messengers that are sent. Don't adopt a one-size-fits-all mindset, as culture and resources vary for each unit. And don't just use education as your sole means. That's been found to be ineffective. However, do use education combined with other mechanisms such as reminders. And as Winston Churchill famously said, never, never give up. Next slide. So let's put all this information and pieces together. Next slide. So this is a scenario solution summary adapted from the website Catheter Out. It can be used for a quick reference as to the type of physician you have and the problem scenario you are experiencing, with suggestions on how to address the problem. So it looks at solutions both general and specific. There is some overlap between the two categories. If you see something in the general approach that can be applied to an individual physician and vice versa, by all means, go ahead and use it. So bottom line is to tailor your approach so that it's appropriate for your culture and resources. Next slide. Thank you so much for your attention.
Thank you so much. That was really a great overview of different strategies that can be used to engage physicians. And I want to close out this portion of the webinar by talking about patient and family engagement. And this is really going to be a very high-level overview to give you a definition of patient and family engagement that are all grounded in the same perspective, but also to give you some benefits and examples of engaging patients and families as partners in reducing poverty in the ICU. We talked earlier in the webinar about these three elements: concerns and fears, skills and knowledge, and system support. Each of these areas have, relevance when we think about the patient and their family. When we think about concerns and fears, obviously one of the concerns is the risk of infection, and especially as it relates to invasive catheters. In terms of skills and knowledge, patients and families really want to understand what they need to do to be part of the team, how they can be involved in rounds. As Jenny mentioned, having bedside shift report with the family members engaged is a great way to be sure that we're addressing their concerns, that they want to understand what skills and knowledge they need in order to be engaged in the care decisions. And in terms of system support, it's important to ask, what does your system do to promote patient and family engagement? Are patients and families included in huddles that are focused on safety issues? Are they given access to the checklist or the teamwork practices that you engage into a particular ICU? And then, do you have family presence policies? But all of these elements have a key message, and that's that patients and their family members can effectively impact outcomes by understanding and supporting the evidence-based practices and really, truly engaging with other team members to adopt these practices. So let's talk about a definition of patient and family engagement. There are many in the literature, but we'll go with the one that Kristen Carmen had in the Health Affairs Journal several years ago. And it's really defined as patients, families, their representatives, and health professionals working in active partnership at various levels across the healthcare system. This could involve at the bedside, at the organization level, as well as at the policy level. But the purpose of this engagement is to improve health and health care. Much like physician engagement, it is intentional and deliberate. And as with the nursing engagement, everyone wants to have an opportunity to be part of the decision-making process. So we have a shared purpose in terms of engaging all team members, especially the patient and family. So when we think about the evidence. It's clear there's evolving evidence, but there is research that's emerging that shows that patient and family engagement translates into improvements, primarily in the areas of safety and effectiveness. We know that we still need to do research that translates what are the specific mechanisms that connect patient and family engagement with outcomes, but this evidence is evolving every day. But ultimately, in order for us to create the opportunity for patient and family engagement, we must create the environment. And the first step to ensuring patient engagement in the ICU or any setting is to really have a culture that promotes and sustains those core principles that involve dignity and respect, information sharing, as well as participation and collaboration. This involves developing mutual respect for the skills and knowledge that the patients and families bring to the table, having honest, clear, and two-way communication that's transparent, especially as it relates to knowledge and information around their care, demonstrating understanding and empathy by being accessible and responsive to their needs, and having mutually agreed upon goals that really are evidence that you have a shared decision-making model. It's about doing things with patients and families, not for or to them. And it's important for us to note that there's a cascade effect of shared decision-making. We know that patient-centered care hinges on having shared decisions. When we have shared decision-making, this means that the process of support informs patients, and informed patients can make better choices and communicate more effectively with providers. That open communication promotes efficiency, reduces waste, and supports evidence-based care. But ultimately, what the research has shown is that informed patients often prefer lower cost and less intensive treatments. So it's really about building an environment that enhances trust, it engages the patients and the families from the beginning, and it includes them when you're setting goals and expectations. This slide shows a few examples of patient-family engagement that we've seen evidenced in high performers in terms of patient engagement in the ICU. Jenny already mentioned including patients and families in bedside shift report and rounds. Also supporting family presence. It's important that we recognize that family members are not visitors. They are family. And that we create an environment that allows the family to be present so they can be active participants in their loved one's care, including patients and families in the quality prevention education, having them actually do part of the education and training. Maybe a patient has had a catheter or a family member who's worked with a loved one that had a catheter-associated UTI, or sharing patient stories in quality team meetings. These are ways that we bring reality to the numbers and to the dashboards and to the checklists that we're using to prevent quality. Many organizations are developing patient-family advisor roles and councils, and by doing so, they are engaging patients and families in ways that are very meaningful, very intentional. And if your system or your organization does indeed have patient-family advisors, encourage them to serve on your quality and safety performance improvement teams. Many organizations have seen the substantial benefits from having the voice of the patient at the table when discussing things like the efforts to reduce infections in the ICU. I think it's also important for leaders in the ICU that are on the call today to recognize that your professional organizations have supported many patient-family engagement initiatives. The Society of Critical Care Medicine, as well as the American Association of Critical Care Nurses, each have a number of different programs that are designed to really elevate the topic of patient and family engagement and to demonstrate that this is a priority in not only the industry and in this area of practice, but it also provides, they provide many resources and tools that you may find useful if you are trying to advance patient and family engagement in your ICU. So it's very important that as a part of this program you ask yourself a few questions, and that includes how does your organization demonstrate the principles and practices of patient and family engagement? What are some of the things that you're doing now to engage patients and infection prevention, specifically in cavity prevention? And what are some of your organization's long-term plans to advance patient and family-centered care across all areas of patient safety, especially in cavity? And also ask if you have someone who's leading or guiding your unit or organization's efforts in this area, ask them to be a part of the program. And we've included in the slide deck today some selected resources that provide some very specific and detailed examples of how you can engage patients and families as partners in safety. I'm going to turn it over to Emily Pathlow, who's going to share with us the tool Learning from a Defect. Thank you.
Hi, this is Emily. So when we're talking about a culture of safety, we're talking about one that is supposed to be safe for patients, their families, as well as staff. And part of establishing a safety culture requires that we have an atmosphere where we look at defects or errors as problems with systems. And a defect, the definition of a defect being that it is anything that anyone does not want to happen again. It really is identifying opportunities to make the work environment safer for everyone. So strategies to identify defects include finding themes among event reporting or common reasons for root cause analysis or sentinel events, and then also things like monthly data reports that identify recurring gaps or outcomes that aren't quite reaching a specific target. In my own experience, I think that a great way to help identify defects within your work environment is directly through frontline staff. So things like daily shift huddles are an open forum to discuss unit successes, as well as talk about safety concerns that staff may have. Staff meetings, they're another way to engage staff in a discussion about safety concern. And last, what, in my opinion, the ultimate best way is by administering the staff safety assessment. The staff safety assessment is an anonymous approach, or it doesn't have to be anonymous, but it can be an anonymous approach to getting direct feedback from staff about patient harm. It asks two questions. How is the patient, how do you think the next patient in our unit is going to be harmed, and how do you think that we can prevent that harm from occurring? So this survey really embodies the core CUSP principles of respecting the wisdom and observations of the frontline staff member. So the process of identifying and learning from defects has to be a balanced mix of both technical and adaptive work. The tool itself is very quick and efficient. It helps keep the conversation on track by organizing action plans to address whatever defect that has been identified. Again, the most important component of this process is that it focuses on what went wrong, not who did something wrong. And this approach can help allow frontline staff to take ownership of defects that occur on their unit, and then also collaborate with other members of the multidisciplinary team, including some people that they may not have an opportunity to directly work with in a normal day-to-day environment. The tool allows for more effective communication. It provides structure around problem solving using keywords at key times. So for example, each CAUTI could be treated like a defect. So in addressing the adaptive work, the goal would be to engage the staff who are directly involved in patient care to work as a team. So collaborating, evaluating their current practices that they know are or are not happening in order to identify the barriers to reaching their target of no CAUTIs. The group may brainstorm different ideas, all while being able to kind of look at the defect through the eyes of others. So as a result, they might come up with and create tools and other types of checks and balances that can address problems with current practice related to CAUTI. So things like checklists or tools to decrease variation in practice, that becomes part of our technical work and can help standardize the care process to help prevent a defect in the future. Through engaging team members, though, to become part of the change, that's where we're really building positive relationships through developing common goals and really promoting a culture of safety. So this adaptive work, that is our CUSP work. Oops, I'm sorry, I need to go back one. Here is an example of a badge card that runs through the structure of the Learn from a Defect process. It talks about what happened, a brief description of the defect. Why did it happen? So it focuses on contributing factors, and it lists examples there of factors. we ask the team, what can we do to reduce the risk of this happening again to another patient? How are we going to know this risk was reduced? And who are we going to share our learning with? So yesterday, actually, we did a learn from a defect during our daily shift huddle on day shift. It took about maybe 7 minutes to discuss a defect that we had found during interdisciplinary rounds for one of our cardiothoracic surgery patients. The defect was that a peripheral IV had remained in a patient for many days after expiration. So we just discussed as a group, what happened, what are we going to do to assist in preventing it from happening to another patient. We want to know what those contributing factors are. What was going on over those past few shifts prior to yesterday that may have been factors in why it was missed. So the frontline staff, they're really who walk the walk, and they really have the expertise and the knowledge needed to improve safety. And the learn from a defect process often takes the pressure off of staff feeling like they are targeted for individual performance. And so now I'd like to just go through 2 other specific examples. In this first example, this is using the Learn from a Defect template that we use here at St. Joe's. It's from about a year ago, and it included working with many different members of the multidisciplinary team across several departments that included the surgical ICU, the OR, and the anesthesia department. A patient was admitted to our unit with a nitroglycerin bag hanging on a pump that was programmed to be norepinephrine or Levophed. So when a defect like this happens, we want to correct what we can right away to prevent immediate harm from reaching the patient. But then we also want to take a step back and look how we can improve the process. And in this case, it was the handoff process or a double check process to ensure that this doesn't happen again. So we determined that there were both people and process factors involved. And during our Learn from a Defect discussion, one of the anesthesiologists identified that often before they leave the OR with patients, some of the IV pumps can malfunction, causing them to have to move critical medications from pump to pump in order to keep them going. The anesthesiologist in this case absolutely had no intention of this error occurring. But we identified other contributing factors that helped make this error reach the patient. So there were too many people in the room, too many people doing too much, and no one was taking charge of what had been done and what needed to be done. We also discussed what helped the defect from being worse. So in this case, the error was caught several minutes after the patient was admitted, and we identified that we already had a few good processes in place, but they just needed some fine-tuning and modification to help prevent the drift that was taking place and help kind of just bring the group back together and remind us of the why behind the standardized process, why we were doing that standardized handoff process. So the big change for this defect is that when a patient is rolled into the unit from the OR, the anesthesiologist and the admitting nurse touch each bag immediately, matching it to its pump to double-check correct dosing. So this takes place even prior to any discussion of what went on in the OR. The final step in the Learn from a Defect is sharing your action plan with those affected by the change. We're very transparent here with our action plans, and we're able to do a lot of this during our daily shift huddles, during reminders prior to patients being admitted to the unit, and even through just direct communication one-on-one. So this second example was from a few weeks ago after a patient fall, and I realize it's a little bit blurry, but the reason why I thought this would be a great example is because it provides an avenue for patient and family input as well. So this is our Super Falls huddle form, and it follows the Learn from a Defect structure. So again, identifying what happened, why it happened, contributing factors, and how we're going to try to prevent it from happening to another patient. So these Learn from a Defect or Super Falls huddles take place very quickly after a fall. This one took about 10 minutes, so this process was pretty quick. And in this case, the patient did already have some fall prevention tactics in place, but we did identify some opportunities where we could have done better for this patient. So the nurse talked about how we needed to include bed alarm checks as part of our bedside handoff process. I thought that this was a great idea and something that we hadn't thought about before. She truly felt that if they would have checked it during handoff, They would have caught that the bed alarm wasn't on, and it could have made a huge difference for this patient. We also had the opportunity to talk to the patient who did say that they had their call light but forgot to use it and needed to get up to go to the bathroom. And what this feedback identified was that maybe this patient needed more frequent purposeful rounding and more specific reinforcement for using their call light. So you can see that we use the learn from a defect process here for many different situations, and I really hope that you found them helpful, and I'll be open to questions later. Thank you.
Great. Thank you very much, Emily, and thank you to all of our presenters for those really, really informative presentations. So I'll go ahead. I'll go ahead and just review some next steps. I'm sorry, Emily, did I cut you off?
Oh, you're good.
Okay, good. Just some next steps for you as you're wrapping up here. So you can assess your ICU's level of engagement of nurses, physicians, and patients and families. So think about, are there opportunities for improvement? What are the barriers that you're facing, and how can you utilize some of the tools presented here today, including the tools presented by Emily, the learning from defects, as well as the case study that Sue presented earlier. And finally, you can review the concepts and tools referenced to bolster your ICU's level of physician, nurse, patient, and family engagement. So I know that Sue and Jenny are having a great conversation in the chat box. I encourage you to post questions there. I'll also ask our operator to open up the lines for Q&A. If you're not able to stay, I do really encourage you to fill out the evaluation. We really are very thankful for that feedback. So I'll go ahead and open up the Q&A now.
Yes, ma'am. At this time, we will open the floor for questions. If you would like to ask a question, please press the star key followed by the 1 key on your touch-tone phone now. Questions will be taken in the order in which they are received. If at any time you would like to remove yourself from the questioning queue, just press star 2. Again, to ask a question, please press star 1.
And if you're more comfortable posting a question in the chat box, please feel free to do that as well. We'll go ahead and read those out as soon as we see them posted.
And we're currently waiting on questions in the queue.
Great. Sue, did you want to say any few final words now that about the case study and any wrap-up?
Well, I think that the case study is really intended to just give a frame and a grounding for the conversation. I would encourage each of the participants, as you go back to your individual units and work with the staff, that you identify your own case studies, real examples where you've had opportunities to engage nurses and physicians as well as patients and family. And more important, that you identify the things that you're doing well. You've heard a lot of information today, and I'm pretty sure that there are a number of leading performers that are on the call today. So start with identifying those things that you're doing well as it relates to engaging key partners, and then begin to identify how do we take it to the next level. I think that's a great way to use the resources we provided to you today, and also for you to help give context to the content that we've presented.
Great, thank you for that, Sue. Chelsea, do we have any questions?
As of right now, we do not.
Okay, well, we'll take 2 more minutes, I think, to wait for questions if anyone has them. And again,
and as a reminder, it's star 1 to ask a question.
Thank you, Chelsea. And as a reminder, all of the materials from today's call will be on the website early next week. That'll include the recording, the slides, and the case study, and any Q&A that we get later on in the call. Okay. Well, if there are no further questions, I'd again like to thank all of our presenters for their time today and for their great presentations. I will encourage, once again, all of the participants to fill out the evaluation. And we ask that everyone who participated on the call fills out the evaluation. So if there's multiple people who are listening in your room today, please make sure that everyone fills out an evaluation. And we will talk to everyone again next month on the July call on July 8th.
All right. Thank you, ladies and gentlemen. This concludes today's teleconference, and you may now disconnect.